All right. Good afternoon, everyone. It is my pleasure to welcome you to the 43rd Annual Interdisciplinary Lecture Series. Again, our theme is Advocacy in Healthcare and Medicine. And I hope what you have realized about the series is that we've been hearing different perspectives on yay advocacy or not so much. And part of the value of hearing different perspectives is to be able to understand if you disagree with a perspective, well, then why is it that you disagree? And you need to understand that. So before I introduce today's speaker, I do want to remind you that next week we don't have conference because it is spring break for those of you who get to go on spring break. But in 2 weeks, on March 19th, we'll hear from David Alfandre from NYU. Today, it's my pleasure to introduce Dr. Thomas Huddle. Dr. Huddle is Professor of Medicine Emeritus in the Division of General Internal Medicine and Population Science at the Hersink School of Medicine, University of Alabama at Birmingham. Dr. Huddle received his MD and a PhD in the history of medicine at the University of Illinois at Urbana-Champaign. He then went on to pursue internal medicine training at the University of Wisconsin Hospitals, postdoctoral historical work as a Robert Wood Johnson Fellow at the University of Pennsylvania. He has taught medical students and residents during a career as a clinician educator at UAB and directed the medical school's first-year Patient, Doctor, and Society course. In his writing, he sought to connect the world of professional work to concerns about medical professionalism, clinical ethics, medical education, and medicine's relations with society. I first met Tom when we were comparing notes. It was the summer of 1985. We were in a program at Georgetown over the summer, and we had wonderful interactions. There were 15 of us, 5 medicine and literature, 5 medicine and history, and 5 medicine and philosophy. And we had great interactions. And then we spoke again this morning. And so we had a little bit of time to catch up, but it is really a pleasure to welcome Dr. Huddle. So thank you.
Thank you, Peter. It is such an honor to be here at the best university in the United States. I say that not merely because of the quality of the faculty and the quality of the work that is done here, but I say it because of this institution's commitment to institutional neutrality and to the careful avoidance of the stifling of dissenting viewpoints. And I think that virtue was definitely exhibited in Dr. Prohaska's invitation to me to be part of this series. I have what I take to be a dissenting viewpoint on this topic, but I certainly welcome debate, and perhaps we can have some of that. So my title doesn't quite totally capture the position I'm going to try to, argue. I'm not completely excluding politics from what ought to be professional work, but I'm actually going to argue something stronger than my title in regard to professional involvement in broader politics. And I'm not going to suggest that you ought not to be as political as you choose to be. I'm not going to suggest that you should not allow your experience as a physician to inform your politics and to be an activist and to be an advocate. All those things are great. What I am going to suggest is that there's no intrinsic or organic connection between professional identity and professional authority and professional expertise with whatever politics we choose to identify ourselves with. I'm going to make a case that medicine and politics we should view as separate realms. We may participate in both, but we should keep them conceptually apart. Okay.
What if I messed it up when I hit on the controls? Try it now. Try that. There you go.
So I want to begin with a little bit of history, not very much. Talk about the present landscape, and probably this will not be news to any of you, but the last 15 years have been momentous when it comes to the medical profession and advocacy and politics. And then I'm going to get into some argument. So I want to start by mentioning this figure, the great German pathologist, Rudolf Virchow. He's not the beginnings of attempts to connect medicine and politics, which was happened in the 18th century, but he's certainly an important figure from our vantage point. He said in 1848, medicine is a social science and politics is nothing but medicine on a grand scale. The context for that was his involvement in the liberal revolutions in Europe in 1848 and his contemporaneous involvement with investigating a typhus epidemic in what is now southern Poland. And he saw the political changes that he anticipated and hoped for from the revolutions as balm to the body politic in Europe. But he viewed public health as another side of that, because the political changes he was hoping for were going to improve the conditions of the lower classes. They were going to do away with dirt and overcrowding and bad air. And that was going to be a solution to things like epidemic typhus. Now, from our perspective, he wasn't aiming at the bullseye, right? This was all before the microbiological revolution of the latter part of the 19th century. But I think it's fair to say that had he succeeded in what he hoped to do, probably it would have helped. It would have helped. Would have helped even more if whatever happened with his reforms were to get rid of the human louse. But that knowledge of that was in the future, of course. Now it's interesting that another German scientist, the great physiologist Emil Behring, looked back on Virchow toward the end of the 19th century and said, well, Virchow meant well. He sought to address epidemic disease with social reform, but the correct path to conquering epidemic disease is scientific investigation, figuring out its causes and then directly addressing those rather than attempting political change. Now, the history of the Western medical profession in the last century has been a conscious decision on the part of most physicians to follow the path indicated by Behring. But as you're all aware, in the last 15 years, there's been a recrudescence of interest in Virchow's path, right? There's been an increasing suggestion that politics ought to be part and parcel of our professional task. Now, you can trace this back to the 1950s. You can trace it back to the AMA Declaration of 2001, which stated that public advocacy was something that physicians ought to do. Prior to 2010, I don't think there was a whole lot of movement on the part of our profession in that direction. I don't think most physicians saw advocacy as something they needed to do. I think probably for most physicians, that's still the case. But certainly the discussion has changed since 2010. And there are plenty of examples of physicians wearing their white coats, self-consciously advocating politically, and doing so with the thought that what they were doing was part of their professional duty. Medical education, not much going on pre-2010. Notably, Canada included advocacy in its competency framework. That did not happen here in the United States. So, just a few things that have happened in the last 15 years. This was a notable one to me because I trained at Wisconsin. These are UW faculty physicians handing out work excuses at a political protest wearing their white coats, flaunting, as it were, their medical identity as something that leads them to this kind of political action. More recent example, one I'm sure you probably talked about in this conference before now, the explosion in 2018 when the NRA had the temerity to criticize the ACP. They had put out a position paper on firearm safety, and the NRA said, "You physicians, stay in your lane." And of course, most of you are aware what happened after that. Outrage among many communities in the physician profession, particularly surgeons, who vigorously contended, this is our lane. What do you mean stay in your lane? How can you even say such a thing? The literature has also become such that calls for advocacy in the medical education process, calls for advocacy among clinicians, among training programs, have been more and more prevalent. The pediatricians have been especially aggressive in this regard, and there are arguments that institutions of medical education ought to make advocacy just as important as teaching, research, and service. The contention is that is just as key, just as core a component of what medical education ought to be about as the traditional three missions of medical schools. And of course, as you all know, in the last 5 years, that level of discussion and physician involvement in advocacy and politics has only gone up, and it's been accompanied by the introduction of politics into the workplace, not only in medicine, but in many, many professions and occupations. And I'm sure you're all aware of that. Corporations, newspapers, journalism, business people, in the last several years, all said to themselves, we need to bring politics into the workplace. This ought to be part of our professional work, whatever that may be. Now, there has been this accelerating trajectory of interest in and the suggestion that advocacy is what we do. The arguments for it, I don't think have changed all that much. And I want to turn to those arguments and try to unpack them and make some points about them. There are four main ones, I think. I'm not going to spend too much time on the first two. I want to spend more time on 3 and 4, which I think are the interesting ones. The first two, I think it's very possible and plausible, perhaps, to suggest that advocacy ought to be part of our social contract. Advocacy ought to be one of our ethical obligations. I think as an aspirational argument, you can probably make that. I don't think you can make it very easily as a descriptive argument. I don't think you can suggest that at the present time, advocacy is part of our social contract. We have a de facto social contract with society, but I would contend that what society expects from us is highly moral and scientific and appropriate and good care of patients. I don't think society is right now demanding that we be political. And I think the same thing would be true of our ethical obligations. Clinical ethics is generally such that we take our obligation for patient welfare and patient benevolence to extend to the patients we take care of as individuals. The jump to groups of patients is a bit of a different ballgame. And most clinicians, at least at the present time, I would argue, are probably not there. Now, the arguments 3 and 4, I think, are the most interesting ones. And we'll start with the first one. Physicians are obliged to further population health. If we're obliged to further the health of individual patients, well, then it follows that we're also obliged to further the health of populations, of groups of patients. So let's look at an articulation of this thought. We know that there are social determinants of health that are more important than healthcare when it comes to health outcomes. As we translate that kind of research into practice, our roles as physicians will necessarily be directed outside of the clinic, where powerful social and political impacts on health can be demonstrated. And this new science suggests that advocacy is in fact a professional virtue, not purely a civic one. Now, so if I want to unpack this, population health and individual patient health, differing assessments and remedies. Can't deny that. Presumably, we would all agree that that's true. Therefore, population health is the physician's job. Therefore, physicians need to get into politics and do politics. Now, for me, there's a missing premise. If I'm trying to charitably make this argument go, the way that it works is only if our obligation to take care of individual patients, which we all acknowledge, directly implicates an obligation to take care of population health. That's how it would have to work. Now, my misgiving is that I want more than simply a statement of a direct obligation, a direct inference from one to the other, because there are important reasons, I will argue, why population health, we should not think of it as our job. And there are mainly three. One is that we're not equipped to address it. Not only are we not equipped to address it, and we are manifestly equipped to take care of patients, there is no prospect that medical education will ever be able to prepare us, as would be desirable, to take care of populations. We would have to become experts in epidemiology, sociology, economics, public policy, and probably several other disciplines before we reach the starting gate of being able to productively think about and possibly address constructively population health. Medical education will never be able to do that if it is going to do its present excellent job of preparing us to be good clinicians. That's just too much. We're already in training for 7 or 8 years. It's not a practical thing that can happen. Furthermore, even if it could happen, as clinicians working with patients, we're not in a good position to address population health. Our institutions, our contexts are perfectly suited for taking care of patients. They're not well suited for changing society. A second reason, the remedies for population health are not as clear as we would want them to be to take that on as our mission. Experts disagree on what to do. I mean, we're getting better at understanding what the problems are, what the disparities are, what the sorts of causal factors are, but how to change things. If we physicians had our fingers on the levers of political power, it would not be exactly clear which way to move them to get a big increase in population health. So that's another practical problem. The first two problems I've identified here are practical problems. The third problem, or the third reason for me, is really the important one. It is the principled one. And it's paradoxical, because for my opponents, the connection of population health and politics is the reason why we need to get political. For me, the connection between population health and politics is the reason why we need to not imagine that population health is our job. So I'm going to make an inverse argument from the argument that is typically made invoking this issue. So how would I go about making that argument? The way I would like to make it is to contrast medicine and politics when it comes to how we practically deliberate in these two realms. How do we go about thinking about what the next move is when we're taking care of a patient compared to what the next move is in making a political decision? Now, in medicine, as I'm sure is clear to all of you, we have a given universe of means that we learn about in our training and that we learn to use in our training, and we have a given universe of ends: health, healing, relief of suffering, as much restoration to function as is possible. I mean, all those things are all familiar, right? And the means to get to those things are familiar. Now, there are goods in medicine that compete with one another to some extent. We do have to trade off some things, right? We have to, sometimes we trade off safety and efficacy. Sometimes we trade off efficacy and convenience. Sometimes we trade off length of life for quality of life, right? Now, the point I would make is that we're used to making those trade-offs. We have some sense of how to do it. Maybe not, maybe those goals are not completely commensurable, but they're commensurable enough that we can make our choices and often agree on those choices. And that brings us to the point that medical deliberation is often demonstrative in a medical community. If I'm doing a CPC and I'm making a case for this is the diagnosis, if I'm a skilled person in whatever the disease is that, or the symptom realm is that the patient's presentation is exhibiting, I can maybe persuade many of you in the room that, yeah, it's right. We can often achieve consensus when, even with difficult patient situations, when it comes to determining a good course of action or a good set of possible directions in which patient care should go. So medical deliberation involves mostly commensurable goods, somewhat at least. If communal among epistemic peers, it comes out of a ground of expertise. It can be demonstrative and we can get to consensus. Now let's think about how that works in politics. The common point, I would say, is that if we live in a small L liberal political community, we do have some agreement on means and ends. What are the political ends? Justice, equality, liberty, security, legitimacy, prosperity. There are various political goods, but we probably have some sense of what those are. And we have a sense of what are the appropriate means in a small L liberal political community. Discussion, argument, advocacy, and voting, right? Now that's where the commonality stops. From here on in, practical deliberation in politics, totally different than in medicine. The competing political goods are not commensurable. I can't translate liberty and equality into some sort of common unit that would allow me to weigh and balance X decrement or increment in liberty with the similar thing in equality. Furthermore, there's nothing analogous to medical expertise in politics. Far from having a common background, a common approach to a disciplinary realm, we have radically varying backgrounds, radically varying estimations of how the world works, radically different senses of which political goods are more important for any given political decision. For that reason, political deliberation at best is never demonstrative. I can never make a political argument and get to a point where you just have to give in. You know, I've demonstrated to you that this political course of action is the right one. I can't do that. You probably can't either. We disagree too much. We value political goods too differently. For that reason, we persuade at best, and we almost never get to consensus. Usually political deliberation settles into patterns of ongoing dispute without resolution. So completely different ballgame. Politics over here, medicine over here. Now, so what do I take from these differences? The first thing I want to say is that population health, when I take it out of an academic context, when I take it out of a disciplinary context or a discussion that we're having in a conference room, and I put it into a political prescription, I put it into a political measure which somebody's going to vote on, population health in that place is no longer just population health. It is politics. Population health is competing against other political goods. I mean, let's go back to that gun control brouhaha that happened in 2018. I'm a physician. I can probably come up with a measure and that, maybe using my expertise, I can determine that it will lead to X improvement in the firearm injury rate. It's a useful thing to do. That's useful information for politicians. But the political decision is what? The political, because if that measure goes into effect, there will be some decrement in the liberty of law-abiding citizens to use or own their firearms in the way that they would like to. I mean, let's assume for the sake of argument that such a measure could be devised. And I suspect there could be one. The political judgment is the gain in firearm safety worth the loss of firearm owner liberty? That's a political judgment. Now, my expertise is very helpful when it comes to making the prediction of how much firearm safety some measure might attain. But does my expertise give me the authority to say, well, you, the population, needs to, or you, the politician, needs to do this political measure because I'm a doctor and population health is my thing, and therefore you have to do it. You need to do it. You need to follow my advice. You need to follow what my professional authority tells me to tell you to do. Well, I would submit that the answer to that question is no. Expertise is very good at sifting relevant information in a disciplinary fashion according to the expert realm of authority, but it doesn't give political weight to the recommendation that follows. The trade-offs of population health against other political goods are what they are, and professional authority has nothing to say to those. So I'm going to, I'm sure a lot of trauma surgeons were totally, let's do very vigorous gun control. But I'll bet you there were some who were on the other side. I'll bet you there were some who were Second Amendment enthusiasts. And what I would wish to argue is that does not, if there were such, that would not tell in any negative way upon their professional identity or their professional work. They're just a doctor with another opinion than the one that many doctors would have. So in political decisions, there's a lot of place for professional advice, but I would argue there's no place for professional authority conferring a thumb on the scale for the political decision. And if that's true, there cannot be a professional obligation to advocate. There simply can't be. If there is not in any given political decision, then there can't be one, period, is the argument that I would want to make. Now, before leaving this point, I want to address an objection. This has been made to me at various points, the objection might go, well, Dr. Huddle, you know, sure, there's lots of political stuff when it comes to health, but surely there are things we can advocate for that are not political, that are simply innocuous health improvements, that need not be partisan. And if so, doesn't it make sense to think of that as a professional obligation that we should recognize? Advocacy can be on all sides. No calls for training in physician advocacy have recommended partisanship. We can sort of thread the needle. You know, you don't have to join the International Physicians for the Prevention of Nuclear War, but maybe you have to do something. Maybe you should do some sort of benign, innocuous advocacy. So this is a hypothetical case, but this was put to me by someone making the opposing argument. Come on, Dr. Huddle, a knee surgeon. Let's posit a knee surgeon sees a pattern of injury among runners from the neighborhood, figures out the injury is related to the sidewalks. The sidewalks could be fixed. Should not that surgeon have an obligation to advocate to the city council to fix the sidewalks, or to do some other, you know, innocuous, anodyne, non-controversial political advocacy? So the problem with that, let's play it out. So he goes to the city council, he makes his case. Some on the city council say, great idea, let's do it. But someone else on the city council says, wait a minute. You know, we only have so much money right now. There's this neighborhood over here that's having a real problem with crime, and we need a policeman over there that we don't have. So right now, fixing the sidewalks isn't the right thing to do. Right now, we need to spend the money in this other way. So at that point, what has happened? What has happened is that the anodyne innocuous advocacy has become partisan, right? It's a topic of disagreement among contending political factions on a political body. That's the definition of partisanship. The knee surgeon's advocacy does good in that it helps the city understand the problem, but it is of no moment whatever in determining what the city council should spend money on at time X. So I don't think this argument works. Any professional advocacy is always potentially partisan. It's never simply warranted by expertise. My advocacy that AK-47s should be made illegal, you know, I can talk about the harms of AK-47s as reflected in the firearm injury rate, but my professional authority has nothing to say about whether they should be made illegal. It always reflects a political vision that owes nothing to professional authority or identity. Once again, therefore, it cannot be a professional obligation. Now, there are some exceptions. I'll get to those. But this is my argument why medicine and politics ought to be separate conceptual realms in our thinking. Okay, now the fourth argument. Not taking political action to further a population health is itself a political stance. And it's a political stance that's unbecoming if you're a physician. How can you be a physician? I mean, it's political if you fail to advocate for population health. And maybe everything is political, and if everything is political, then you need to make sure your politics as a professional person are becoming or mindful of your professional identity. So here's somebody making this case, making this argument. Not acting is another political position. It may be among the most powerful of advocacy tools. Martin Niemöller said, well, first they came for those people over there, but that's going to lead to them coming for you. Medicine, inexorably linked as it is to money and power, is an inherently political vocation. So Virchow is back. So I want to unpack this thought also, and I want to try to make sense of it because Because the contention that everything is political, I don't think passes the sniff test. We spend a lot of our time trying to cabin off the political to the public realm where it belongs. We spend a lot of our time trying to keep the political out of our personal lives, out of our professional lives, out of our friendships, out of our family relationships. When the political gets into those relationships and disrupts them, we generally view that as undesirable. Interpersonal context can be political, and very often we don't like it when that happens. Now, it's true, Carol Hanisch, very interesting lady, wrote an essay in 1970 entitled "The Personal is Political." What did she mean? What she meant was that personal relationships, such as marriage, if they're enacted in a particular social context, let's say the social and cultural milieu of the 1950s, that's going to affect their shape. And maybe it's going to affect their shape in a negative way. And so the personal can be affected by political considerations. I think that's indubitable. That's clearly the case. But it doesn't follow that personal relationships in general are political or ought to be political. I want to make the argument they generally ought not to be political. So the everything is political tactic, I don't think goes very far. Is there another way to make this argument more persuasive? Is there another way to sort of unpack this argument in a different way that would make it more understandable, more plausible? And I think there is. So I'm going to try to get at that by offering another example or two. Here's Don Berwick in 2017. He says, well, there are these huge social problems that are staring us in the face: war, ignorance, families unhoused, children unfed, refugees at our gates. And he goes on to say, okay, so look at these huge problems. Now look at the medical bodies, look at the professional institutions, the physician groups. They think they can be bystanders. Well, Berwick says, no, the seat of the bystander is gone. To try to avoid the political fray through silence is impossible, because silence is now political. Either engage or assist the harm. You better go to the barricades and start fighting to address these problems. And if you don't, as a professional, you're a bad person. You are morally lacking. Another example, Eric Reinhardt, medical anthropologist, Chicago person. As underlined by the tradition of social medicine, the practice of medicine, let alone public health, is intrinsically political. To deny this is a political act in service of the status quo of U.S. health capitalism. If you're not fighting U.S. health capitalism, you're not doing the right thing. We need to explicitly politicize medical care so that we can organize for redress of bad policy that is killing people. So once again, get on board, get on the train. If you don't get on the train, you are condemned. Now, this to me is a much more comprehensible way to understand this argument. It's not so much that everything is political. It's more that when the situation is really dire, maybe usually non-political forms of association and parts of life need to eschew their avoidance of politics and get into the political fray. If things are sufficiently going horribly, then we need to step up to the plate, including in our professional life. I think that's the form of this argument that makes sense. And I think if they left it as an appeal, I think it would be a very attractive argument, and that all of you who are inclined to progressive politics would likely, this would strike a chord, and maybe you would get on some of these trains. I think it becomes a little different when the contention becomes, well, if you don't, then you're being a bad person, you're being politically vicious. When they say you're being political, what that really means is you're being politically bad. So are there circumstances in which it might be politically bad for us not to get involved with a political issue? That's question one. Question two, are the circumstances that Berwick and Reinhardt identify circumstances that merit the kind of demand for action that they offer? Now, the answer to the first question, I'm going to say is probably yes. But the circumstances I would identify are not circumstances of broad politics. They're circumstances of direct threats on the integrity of the medical profession. That has happened in a few places at a few times. It happened in Germany, happened in the Soviet Union. The honorable thing to do if you were a German physician in 1933 would probably have been to totally disassociate yourself with the official German medical profession. Things like that might come up that would lead us to need to act. The second question, though, what about Berwick and Reinhardt? What are the priorities that Berwick and Reinhardt feel warrant this urgent call to political action, or else? Abolishing private health care for Reinhardt. And then for Berwick, it's a number of different things. And generally, it's a kind of menu of progressive political priorities. Joining the Paris Agreement, realization and statute of healthcare as a right, abolishing the Electoral College. If you're not at the barricades doing these things, you're a bad person, okay? I would respectfully reply, no. If we live in a small illiberal polity where there is going to be pluralism among physicians as among other citizens, there will be political disagreement on a broad range of issues, including these. It is perfectly compatible with being a good professional. We are going to disagree with one another. That's inevitable. That is somewhat celebrated at this institution. I think we should accept that we're going to disagree with one another and engage with one another, and allow fighting it out among competing and conflicting ideas to hopefully enlighten us, hopefully make us think better, whether it changes our mind or not. That's true for the medical profession just as it is for the academic community. So my conclusion about this argument, professionals not being political might be blameworthy in certain dire emergencies, but in a very wide span of political differences, it's not only permissible, but it's called for. And the kind of argument that Berwick and Reinhardt make, I would want to contend, is not merely erroneous. It is pernicious and it is destructive. To suggest that people who politically disagree with you are bad professionals. We as professionals ought to be able to politically disagree and yet have professional fellowship and collegiality and comedy and friendship as we go about doing our professional work, in spite of even very vivid political differences. We should keep our political fights out of our professional work. So I conclude, medicine and politics are very different realms. Even if politics can serve public or population health, if you're a physician, be political. Let your professional identity inform your politics. Absolutely. Just don't mistake your politics for an imperative that comes from your profession and your professional identity. Don't confuse those two things together. To become a professional is to sign up for a job. We need to do our jobs as professionals. And I'll end with the note of advice that Stanley Fish gave to the American Professoriate 17 years ago now. He said, if you feel inclined to save the world, by all means, go for it. Do it. Just don't mistake that endeavor for professional work, which it is not. Thank you.